Welcome and thank you. Welcome and thank you for joining us today. For those that are new to RISE, we are the premier community for healthcare professionals, facilitating connections and providing insights through virtual and in-person conferences, online courses, certification, and timely content in webinars like this one. We are made up of communities with 3 key areas of focus: quality and revenue, Medicare member acquisition and experience, and social determinants of health. Today's webinar is the latest in a series of webinars produced by the RISE Association and our community partners. Now for a few housekeeping items before we get started. During today's presentation, if you have any trouble hearing us, you can access the audio via teleconference using the dial-in information that is posted in the chat box. As you may have noticed when you joined, all attendee lines will be muted for the duration of the webinar. Please post any questions you have for the presenters in the Q&A box, and we will answer them either during the webinar or at the conclusion of the presentation. Please note that today's program is being recorded. The recording and presentation will be shared with you within the next few days. They can also be accessed within the RISE Association member portal. Please provide feedback on your experience with us today using the survey that will pop up at the end of this presentation. We greatly appreciate your feedback about your experience so that we can continue to create content specific to your needs. Thank you for joining us today.
Hi, I'm Margaret Porosky. I'm a physician. I've been in practice for over 40 years, and I serve as the CEO and Chief Medical Officer for Catholic Medical Partners. We are a 900 physician independent practice association, and we contract with our payers to achieve quality metrics and to achieve shared savings and total cost of care.
And hi, I'm Brian Flower, VP of Client Solutions for Vatica Health. I've got 16 years of experience in risk adjustment and quality, the majority of which has been focused on prospective solutions in primary care. And for Vatica, I help to identify the voice of the client, contribute to program innovation, and lead certain elements of our analytics. Thank you for taking time out of your day to attend our webinar. We hope to make it worth your while, starting with a quick note about the landscape of risk adjustment today, and then a deeper dive into 2 benefits and 2 challenges health plans face when engaging PCPs directly as a primary strategy in risk adjustment accuracy. Dr. Porosky is offering up a provider's perspective so that you can leave this session with a checklist of winning ways to address these benefits and challenges. And we look forward to addressing your questions before letting you get back to your afternoon. It is probably safe to say that Medicare Advantage risk adjustment has undergone more changes in the last 6 months than it had in the prior 6 years. The RADV final rule codifies extrapolation and sets a high bar for audit compliance. The OIG has been very forthcoming about the types of submissions they see as the highest risk, including single submissions by someone other than the patient's care team. And next, the 2024 final rate notice introduced significant changes to the model, a reduction in the number of diagnosis codes that risk adjust, and a shift in the coefficient weight for many conditions. These changes reinforce the importance of that which remains the same. The goal remains completeness, accuracy, and specificity. Documentation remains the source of truth for compliance. And the HCC RAF score will still be based only on codes documented within the annual measurement period. And Dr. Porosky, I will push that last bullet point to you.
The primary care physician has provided care for the patient in many cases for many years, integrating input from multiple specialists and formulating a care plan. That puts the primary care physician in the best position to put together all of the pieces of the jigsaw puzzle to arrive at a determination of the patient's complexity, and their associated risk score. Now, none of us went to medical school to be coders, and coding can be complicated, but our request is give us resources to help us. Don't try to replace us.
Here begins our benefits and challenges. Benefit number one reinforces the idea that PCPs are the best source to maximize compliant coding capture while keeping the PCP at the center of the care team. Dr. Porosky, what should listeners know about how to realize this benefit?
Well, the first thing that providers need is timely data. When we get sent a gap list that is 3 to 6 months old, it just wastes everybody's time. A lot of times the gaps in care have already been addressed and we're doing the same work twice. The next thing we ask is present patient-specific data within our clinical tools. Don't ask us to go in and out of multiple payer portals. In my area, we have 4 major payers, but there are at least 6 other payers with significant market share. You can't expect a busy primary care physician to be going in and out of 10 different payer-specific portals during the course of a day. And of course, every portal is set up a little bit differently, which makes it hard for the physician to be able to readily navigate these. Give us a single tool that we can use with any payer. And that way we become familiar with the tool. It's quick and easy for us to use. It's efficient, and we're all going to get better data and better outcomes. When you're asking a provider to accept a diagnosis in building the risk score, please categorize clinical data with the sources to support what you're asking us to validate. Sometimes it's easy. It's a code that the primary care physician themselves has used in the past, and it's pretty self-evident. So the patient has a leg amputation. Not very hard to determine whether that really happened or not, although very honestly, it remains a mystery to most primary care physicians why that has to be redocumented every year when the patient's leg clearly isn't going to grow back. Next, we have diagnoses that have been put in the record by other providers, and these are usually specialists. And I think the payer makes the assumption that we automatically have all these consults from specialists. Well, even in an era of digital data and things being exchanged fairly rapidly, a lot of specialists don't send us their consults. It's particularly a problem for those of us who live in the chilly north and our patients are snowbirds and migrate down south for the winter. They often have a doctor in Florida who doesn't send us any reports at all for their care during that time. So we're asked to accept these codes. We need to know what that specialist saw and see if we agree with it. We may or we may not. And specialists often take a history and add a lot of other codes for conditions that they're not the primary person treating, and they may or may not have gotten it right. And then finally, there is the dreaded suspect codes. And these are codes that have been inferred from sources like laboratory data or medication lists. So, for example, if you have 2 marginally elevated glucoses on a patient that were done as part of a metabolic profile, and I know that that patient never fasts for their lab work, they have a normal hemoglobin A1C, I am not going to concur with a diagnosis of prediabetes or diabetes because that's not what the patient has. Similarly, if off a medication list, you pull off that they're on an antidepressant and ask the primary care provider to validate that they have depression. Antidepressants are used to treat a whole host of different clinical conditions. So it may be that the patient has an anxiety disorder or has insomnia or a chronic headache or a chronic pain syndrome. Unless you've got data pulled out of that record that documents that they actually have scored as having depression on a standardized tool or have given a history that is suggestive of depression, the primary care physician is not going to feel comfortable validating that code. So please don't overwhelm us with these low probability suspect codes that there's no data to support. Do give your primary care physicians coding training. Now, the PCPs are not going to have time to learn every nuance about coding, but at least train us in areas where mistakes are commonly made. When does a stroke stop being a stroke and we should be coding it as sequela from the stroke? Versus when does a patient still have cancer versus a history of cancer. As you move from disease to disease, the guidelines actually vary for coding and aren't consistent with each other and can inherently be confusing. The other thing is let us know when something that we might not think is a particularly high risk condition is important to document so that we make sure that we get those things that are really going to count in the risk score. Remember that physicians actually really are interested in compliance. We all lived through the fee-for-service era where we were using E&M codes that had lots of different things, checkboxes that you had to meet in order to qualify for that code. We all lived in fear of getting dinged on the False Claims Act. Well, we don't want to move from that era to an era where we are going to be complicit in risk score inflation. We want to do things right. So again, don't ask us to validate low probability codes, and please don't overwhelm us with payer-specific solutions. We just don't have the time to go in and out of all those portals all day.
Thank you. And one point I would throw in regarding PCP training, what we've seen over and over again is that when you apply a given training topic to a PCP's actual patients on an encounter that is recent, that we get a tremendous amount of traction there. Obviously, the learning is going to be more effective in that environment.
Yes, you would think that we don't want to be audited, but there are situations where we really do want feedback, and the closer that feedback can be to the time when we did the coding, the better.
Okay, moving on to benefit number 2. Engaging the PCP improves the outcomes for the patient, for the PCP, and for the health plan because you're investing time, dollars, and data in fostering that primary care relationship, which leads to improved utilization management, care plan adherence by the patient, and whole patient care. Dr. Porosky, I'll push it back over to you for insights you'd like to share on this topic.
Sure, I would encourage the payers to provide a clear strategy for where value-based care is evolving to. We have a local retailer whose motto is that an educated consumer is their best customer. And that same thing is going to be true for you when engaging with physicians. If we have some idea where you're going, we can build towards that. You really can't expect us to do the 1-mile fun run this year and then run a marathon for you next year. There's a whole lot of steps in between that we need information on. It's great actually to get data, even if we aren't being currently incentivized for it, that's going to be a building block for where we're going. I can guarantee that the average practicing physician cannot tell you what MLR means. Similarly, give us data, even if you're not incentivizing it, on our ED utilization, our readmission rate, what our hospital utilization looks like compared to what you would have expected based on our risk scores. Present data to us that goes beyond just HEDIS and STARS data. There are a lot of things that are important that impact care that aren't included in HEDIS and STARS. Probably the biggest one I would highlight is social determinants of health. When we take a look at a patient's current health status and say what impacts that, we know that their physical environment does. We know that their personal habits do. And as physicians, we all like to think that our clinical care has a big impact. But far and away, the single biggest factor is social determinants of health. And this is one where we need joint payer-provider strategies to be able to address them. We know that if a patient has social determinants of health, those can be barriers to closing quality gaps. We also know that a patient with social determinants of health is often overutilizing the emergency room, that they are getting admitted for social reasons, and that they're getting readmitted. Whenever we utilize a medical solution for a social problem, it's going to be costly, and it's not going to achieve the endpoint that we wanted. So CMP has actually had the experience with partnering with multiple payers in our area to address social determinants of health. The first thing we did was to get people to document them. And so we had a process metric where we actually got our providers to build questions on social determinants of health into every annual wellness visit, regardless of what EMR they were using, and to start using Z codes so that we would be able to track that data. But as physicians, we're trained to solve problems. We don't want to ask about a problem that we can't do anything about. So primary care physician does not want to say to the patient, oh, do you have trouble getting healthy food? Oh, do you have a place to live? And then when they say, yeah, I can't get food, I don't want to turn to them and say, that's sad. I want to have a solution to offer them. But the same way that I didn't go to medical school to be a coder, I didn't go to medical school to be a social worker. I don't have the time or the expertise to be a social worker. And so in our partnership with the payers, we were actually able to get a funding stream for CMP where we could afford to hire multiple social workers. And these social workers service 55 practices. When our providers identify someone with a social determinant of health, they refer them into our social worker who will provide the services needed for the patient and then get a note back to the provider along with a suggested Z code for it to be incorporated into the patient's medical record. These are the kind of partnerships that ultimately will impact things like ED utilization, hospital utilization, readmissions. And it's important for you to be our partner in those things. Let's find those programs and work to build them together. My next plea under the don'ts is do not abandon us after you have auto-assigned members to us. Auto-assignment is often code talk for we don't know where the patient is. So we get an auto-assigned member and we find out that the address they supposedly lived at is 3 addresses ago. The telephone contact we have is out of service. We can't close gaps in care. We can't do an annual wellness visit and capture a risk score on a patient that we can't find. So what is our solution? We try to get a hold of them a couple of times, and then we send a letter discharging them from our practice. But that really is just squeeze the balloon because the minute we discharge them from a practice, you're simply going to auto-assign them to another one of our practices, which really doesn't address the issue at all. And as we're evolving in value-based care, give us a clear idea where our performance is. We need a place to see how we're doing that's easy to find, easily intelligible. We want information that's clear and that's actionable.
And on auto assignment, from a program perspective, I can speak to the frustration that PCPs feel on how auto assignment corrupts the denominator. We will have PCP groups that lean in fully on a given metric, on a penetration rate. Can we take the program this far in a given year? Once auto assignment is plugged into that equation, it becomes very difficult to measure that success. Sure, there'll be PCPs that are well over the threshold that we're looking for, and there'll be PCPs that have no chance of making it. But it's the PCPs on the bubble that made an attempt, intend to engage fully in the program, and will be most frustrated by 15 or 20 additional patients that are added by auto assignment and create a barrier to them making those thresholds that they felt like they were on track to make.
We've actually partnered with community health workers where we've sent them out into the community knocking on doors to track down and find the patients.
All right, switching gears, we're going to focus on the first of 2 challenges, which also should come as no surprise to anyone. PCPs are busy and they are overworked. So Dr. Porosky, if we want PCPs to take on more and engage directly in risk adjustment, what should health plans and program managers keep in mind?
Well, the first thing you have to recognize is just how busy PCPs really are. There's a 2002 study that showed that if a PCP followed all the nationally recognized guidelines for preventative care, management of chronic disease, and management of acute conditions, they would need 26.7 hours in the day to see the average number of patients that a PCP is expected to see. That is just not doable. Now, I said before, don't replace us, help us. So how can you help us? Well, allow every contributor to operate at the top of their license. You are not utilizing a physician well when you give them a bunch of administrative tasks or send them off to do prep work in a chart. And so if you were to take a look, go to a Michelin 3-star restaurant and see what the master chef is doing. I can assure you they're not in the back chopping onions because that master chef is going to have a sous chef, a line chef, prep cooks, individuals who are sourcing and preparing the food, someone who's cleaning up the kitchen as you're making the meals. As a physician, we need those same type of resources. Similarly, for busy professionals who don't have time to go to the supermarket and prepare healthy meals, you can get a service like Blue Apron to deliver a box to your door that has all the food you need and just the right proportions to prepare a healthy meal, and then it leaves you to cook the meal. That's what your physicians should be doing for you. You should have all that prep work done and just ask them to do what you need a doctor to do. And that's the final job of putting together the risk score or closing the gap in care. So where are these staff going to come from? Well, sometimes you can utilize the staff that are in the physician's practice. But remember, those staff are part of a primary care's overhead, and that's expensive. The average primary care physician post-pandemic is operating at a 70% overhead. And so you need to compensate for those staff's time. Sometimes the payer can step in and provide the staff to do the prep work, or the payer can partner with a vendor that does the prep work for the primary care practice. Uh, Primary care practices are having a lot of trouble finding staff. The cost of staff, particularly nurses, has gone up astronomically, and you will find that there is no loyalty. The average person working in an office will go down the street for 50 cents more an hour. And so primary care practices find themselves overworked, understaffed. They're constantly hiring and training, so that if a payer is able to respectively step in and give us that help, or again, find a vendor that uses a common tool that will do the prep work for us, it's going to be a lot more efficient, and we're all going to be a lot happier and get through our day without constant interruptions that are just inefficient.
Let me jump to the second challenge that we're going to address, and it has to do with all of the other expectations that we place on PCPs outside of patient care. And I think it's important to remember that when investing in in-office assessments, the PCP is not the program. They are the care provider that we need to empower. So PCPs are less likely to lean in if their time and expertise is undervalued or if their role is marginalized. Dr. Porosky, we'd love to hear from you about your thoughts on this challenge.
Well, our first request is to pay us fairly and quickly. Primary cares are already the lowest paid on the food chain in healthcare, and they have the highest overhead in the office. Cash flow is tight, and most primary care practices have limited, if any, reserves. So when you keep piling on tasks and tell us, oh, it's all in the capitated rate, really what you're doing is giving the physician more to do and paying them less. I think we all agree that the annual wellness visit is the holy grail. This is where most of us are going to be looking to have some time to finally give the patient some counseling on preventative care. It's when we're able to close the care gaps, and it's when we're able to pull together all of those conditions to be able to come up with the patient's risk score. PCPs will arrange those annual wellness visits in their office, but often what they find is that the payer decides instead that they're going to send their own provider out to do a house call visit. That could be a physician or a nurse practitioner that's not part of the PCP's practice, and they send them out to gather this information. And the PCP often would be more than willing, if the patient really needed a house call, to go out and do that house call themselves. But what you find is that when the payer hires people to go out and do these visits, they typically carry a relatively low caseload for a given day. So they might be seeing 4, 6 patients. They're being compensated for their windshield time. They're being compensated for the time it takes to document. And yet when they turn to the primary care provider, they'd either say that the house call is part of the capitated rate, or they would offer a relatively low amount of money to do that house call visit that would not have built in the amount of the provider's time that they would spend in travel or the amount of time that they would spend in documentation. And so I would suggest that you don't cut your primary care providers out of this opportunity, but you train them, utilize them, and pay them fairly with a carve-out amount. The other thing that I would point out is that I have had the opportunity to listen to folks from the Office of the Inspector General speak on multiple occasions, and to a person, they agree that for the OIG, the single biggest red flag is when a payer has sent someone out to the patient's home that is not part of the PCP's practice, for a single visit because their view is there's only two things that can happen here. Either the provider sent out by the payer collects all these diagnoses that the primary care physician would not agree with, and that's where we're coming up with risk score inflation, or they would identify legitimate conditions, but because it's a single visit and that information isn't being conveyed to the primary care physician, there's no treatment and there's no follow-up. And neither of those is a good solution. So when you take a look at what the primary care physicians really want, we want the payer to stay in your own lane. Don't try to practice medicine. Let us care for the patient. Give us the resources that we need. Don't carve us out of care decisions. Don't ask us to stretch our credibility on coding. And most of all, don't expect us to fill in the gaps from potential erosion of the risk score under version 28 that Medicare has come out with.
And it was striking for me, the concept of doing in-home assessments that are driven by the PCP instead of an outside entity. And in the work we do, over and over again, we've learned if you're making a phone call from the PCP office, the patient is more likely to answer the phone. If you're making a request of the patient to have an annual wellness visit, whether it be in their home or the office, they are much more likely to respond positively to that and engage if the request is coming from their trusted primary care physician or their team instead of the health plan. So any opportunity that you have to engage via that route is going to be much more effective and drive up in-home assessment rates, as well as ensuring that the results of that in-home assessment of that encounter end up back in the EMR, end up affecting the care plan, driving the referrals the patient needs, and the follow-up that the PCP is likely going to need for many of these patients in this population. All right, we're doing excellent on time. So thank you, Dr. Porosky, for all the content and for doing most of the talking. That was very nice. And for our webinar listeners, I hope you found the content informative and helpful. As we head into QA, we've pulled forward a couple of points from the previous slides to kind of sit on the screen and become indelible in your minds. And I can switch over and start pulling in some of the questions. So we do have a question in the question and answer box. We've got a couple of other questions. First question is from Shelley. As a risk adjustment coder, we provide pre-chart prep work. How much clinical information can we provide without going outside of scope or leading? How would you start that response?
Well, I think that you look for the information that would be needed through common sense to support a diagnosis. So if you're giving me an MRI with white matter disease that a radiologist has read high burden of white matter disease consistent with vascular dementia is not a radiologic diagnosis, it's a clinical diagnosis. And so I need someone to have gone in the chart and pulled out a mini mental status exam score or something from the history that tells me that the patient or their family members have complained that they have cognitive impairment. Something where if you're going to put a diagnosis down, there is anything in the EMR that is clearly going to support it from both a clinical and a diagnostic study basis.
We see the same thing. So when we pull biometrics forward from PCP's EMR or from a consult note, that's very clear evidence that we're presenting for their evaluation. I think the second element that we'll see is to the extent that you can suggest or present the evidence for a more global condition and allow the PCP to do the work of making the decision tree choices of the 6 or 7 or 12 conditions within that bucket that would apply to that case, then you're keeping the PCP's hands on the wheel with respect to what decision they're going to make around choosing the appropriate diagnosis code and alleviate some of your concern around leading PCPs. We have another question that came in. Do you know the national rate for diagnosis recapture, and what is your organization's goal?
That I don't have an answer for.
I have the answer written down right here. No, I'm kidding. It's incredibly difficult because the way that the provider organization is structured is going to make a tremendous impact on your recapture rate. Are they able to refer within their system to specialists that the patient already has a relationship with to recapture those codes that are tougher to recapture in primary care? There's a big factor. Geographically, how far does the patient have to drive to make sure that the annual wellness visit rate for that practice is high enough to achieve the recapture rate you'd like? There's a ton of factors that are going to go into the program itself. How current, and Dr. Borowski touched on a number of these, how current is the data that you're presenting to the PCP ahead of the visit they're about to have? So based on your question, anonymous attendee, I believe that you already know all these things. And I think the important thing for setting an organization's goal is to do just that. Set the goal at the organization's level based on their prior performance, and pay very close attention to either the HCCs, or if you can bundle those HCCs, bundle the ICD-10 codes at levels that are a bit more granular than the HCC level. You can set goals based on a new blend. There are conditions that are very likely to be revalidated or recaptured, and there's other conditions where it's much more difficult. So when you start setting that bar and taking that into account, then I'd say the goal is going to be look at last year, make sure you have your weightings correct, and set a reasonable expectation for improvement. I think the last thing I've seen over and over again as well is go down to the MPI level. And this is where auto assignment becomes incredibly important. If you're looking at these statistics and these performance metrics at the MPI level, I think just as often we have seen when we engage with a practice that 80% of the practice is meeting the goal and 20% are not. In the other case, you could have a practice where across the board, revalidation or recapture is a new concept. So across the board, you're going to see low rates. You got to be able to tell the difference, again, at the organization level between an organization that needs global help and an organization where there's certain PCPs or certain providers, NPs, PAs, that really need special attention, get on a program, get educated so that they can bring the practice metrics up. I'm hoping that was a comprehensive enough answer, especially considering we gave you no numbers that you were asking for in that question.
I will say that our IPA in our contracts with payers does set goals for annual wellness visits. And we get monthly stats on who's gotten them done, who still has them outstanding, so that we can follow up with individual providers to make sure that those get done. We are also fortunate that the payers in our area have picked a common vendor and a common tool for the annual wellness visit, so that everybody is very well trained on how we're going to go in and capture all of those conditions and have confidence that they are compliant.
Agreed. Our payer partners, they'll each have a different revalidation goal across their population. When we dive in and consult on those goals, we'll see that those goals are largely driven by how specific they are with which conditions they expect to see a high revalidation rate. The new V28 is obviously going to complicate that. So we've got to take a second look, relook at mapping, et cetera. And on that, sorry, go ahead.
I was going to say another thing that we have done is spent a lot of time with our specialists getting them to code accurately. And while you would say, they're fee for service, they're going to get paid regardless of what they code. We have emphasized to them how important it is to code accurately, because their codes are going to be used by the primary care physician. So if you're a neurologist seeing an MS patient, yeah, you're determining the MS code. But the primary care physician, when they're treating the patient for their third urinary tract infection this year, is going to be saying, oh, they've got MS, maybe they've got a neurogenic bladder, or maybe that disease-modifying therapy they're on that's so immunosuppressive is why I'm seeing so many infections. It's very important to know whether that neurologist coded a clinically isolated syndrome or relapsing remitting MS on a high-risk drug. And so getting our specialists to understand that their coding does make a difference for the patient's care as a whole has been an important step.
And the questions are pouring in. So the next question, Dr. Porowski has the best analogies I have ever heard. Brian, which one is your favorite? That question came in from Brian Flower. I am going to link that question to a question that actually came in. How do you get providers on board with VBC and revalidation? Because my favorite analogies of the webinar was the 1 mile fun run preparing for a marathon the next year. And that resonated for me because of the number of conversations that I've had the pleasure of having with provider organizations that are all over the spectrum on VBC, all the way down to a PCP office with, say, 350 attributed lives with a given payer. And when we begin to talk about the not just the incentives of a specific program, but the financial implications of setting the appropriate threshold for this population you're responsible for, oftentimes we're having conversations about how fun runs are fun. We're really starting at that first space to say you might want to lean in and get interested in this. I know you got a lot on your plate. I know that while everybody else feels like they're largely back from COVID, there's still remnants of that you're dealing with, and that the VBC ambitions you had prior to COVID, you're starting to figure out how to lean in and, all right, let's reset and learn about this. Keeping that mindset of asking the questions to figure out where the provider organization really is on value-based care. Get the connection, understand what they truly know and what they don't know. They're decision makers, and figure out, are they at the 1 mile fun run? Can they handle a 5K? Are they ready for a half marathon? In setting up, to expound on what you were referring to earlier, Dr. Porosky, that continuum, that VBC strategy should be fairly clear to an organization, to a provider organization, around what stage are we at? We're talking to you about this. The reason why we're doing that is because 2 years down the road, when we have you here, when we have you at half marathon, these things are going to be very important. So how do we make time? How do we train both mentally and to produce the tools that you're going to need to be in that position to be successful when you're running the half marathon? So how do you get providers on board with VBC and revalidation? What else comes to mind for that, Dr. Porosky?
Basically, I think the way you get people engaged is twofold. One, you incentivize them. Time is money. And if you're expecting a physician to give up their time to engage in this, it's important that they see some compensation for that. And then the second is to give them data that is clear and specific. We are always taking a look, let's say, in our total cost of care contracts with the payers, to have them come back with data that is specific and actionable. So when they come back and say, oh, you use too many specialists, well, which specialists? And, can you tell me specific providers that are a problem? It's really not helpful to get data that you can't do anything about. So it has to be directional. And if there are folks that can bring in that can help us find those right directions or find solutions, that can be very helpful.
One more thing I'll throw in there too is benchmarks. So when again, if we're talking about a PCP group that's relatively new to this focus, helping them understand how PCPs that are like them are performing, you win either way. If you show a PCP practice that on revalidation of a carefully selected subset of highly chronic codes, that they are performing under the average, they get very specific information about, this is the standard, I am below the standard, and a very realistic gap to close to get there. If they turn out to be outperforming the benchmark, what you will have is a PCP organization that trusts your data and other metrics that you want to push them on, other metrics, whether it be quality, whether it be social determinants of health, et cetera. You've got somebody leaning in that says, they're not just asking for things from me. They're not just showing me areas where I need to improve. They're showing me where I'm succeeding, and they're showing me where I've got work to do. Like any of us, that produces a level of trust and engagement and kind of a lean in that you're looking for to then continue that relationship.
And we've certainly found that, say, with the patient experience goal, which, is now a quadruple weighted metric, we had a lot of physicians who said, oh, I'm fine. My patients all love me. I don't need to think about that. And then surveys started coming back, showing that they were in the 4th percentile and they were losing all the incentive they were going to get for patient experience. All of a sudden, they're interested in our training on how they can improve their patient experience scores.
I have one more question queued up. So if there are other questions, I think we still have a couple of minutes if there's anything else you'd like to ask, but I'll jump on the one last question that we have queued, which is I'm relatively new to risk adjustment, but I'm wondering how open PCPs are to receiving incentives involving recapturing year-over-year diagnoses. Do they work? How would you start that response?
I think they work because we have a number of payers that will actually pay by the code for physicians to go in and validate them as a yes or a no. And they get paid whether they say yes or they say no. So they're not being incentivized to validate iffy codes. They're being asked to look at them and make their own judgment. And that's actually the really important thing for physicians, is to feel that they are not in an ethically slimy process, that you are really valuing their opinion and you're not pushing them in one direction or another. I will tell you that if you bring a tool to a primary care physician and you've got 10 codes, 8 of them are suspect and outlandish, there's not going to be an element of trust there. If you have a handful of codes and you've got information to back it, then they're going to feel very comfortable giving you a yes, no, and feel like they're part of a compliance process with a payer that they can trust.
And this is going to sound obvious, but I will state it anyway. When you plug a PCP into a program and you ask them to do, when we're talking about PCPs being busy, you're asking them to do that bit of additional work, whether it be during the patient day or whether it be during their admin time, that you're adding an additional task for them to take care of. There's a big difference between asking their staff to submit paperwork for them and asking a treating PCP to lean in and participate. So the obvious portion of this is when they are reimbursed with an incentive to participate in these programs, whether it be code by code, whether it be one visit per year, et cetera, ask yourself if the reimbursement structure you've set up, if you were the PCP, would you connect the dots that that incentive is tied to that activity? Because if no, you will not get the traction, right? So we've seen a bunch of different options. We've seen specific, we work with people to make sure that specific incentives are associated with the patient list that they addressed. We've seen that it rolls into the PCP's larger goals. But if that doesn't appear on the dashboard where their larger goals are displayed, then it's going to get lost in the shuffle as well. So I think that's the major thing is can a PCP truly tie the reimbursement they're receiving to the activity they participated in? And there are actually 2 questions in the chat. Can I ask, do we have the time to get to those? Or can we just run long and leave it in the recording? I'm going to say silence means we go. Yes, we can go. So 2 additional questions. Any parameters through your incentive models to ensure providers address all conditions appropriately and also submit all appropriate data electronically and with the appropriate documentation? I have thoughts here.
Go ahead.
You want me to go for it? Okay. Dr. Porosky described how you need to take tasks out of the PCP's hands that is not primary care work. And I think the second half of your question is a great question. And also that they submit all appropriate data electronically and with the appropriate documentation. And mine might be a little biased. I'm from Vatica, but if you take that process off their hands, make sure that you're engaging in a program that rolls that into the workflow so that when the PCP finishes their work, that process is automated. It gets QA'd, it gets packaged up, it gets submitted to the health plan. That to the extent possible, the documentation gets submitted to the health plan as well, and you're not asking the provider to do that. Because I think I know where you're coming from on this. It is difficult when PCPs do engage, and if there's 3 more steps down the line, that creates more and more opportunity for the loop to not close. They're participating in the program, but a certain percentage of their participation isn't recognized because it wasn't submitted. So I would say attach to the program as much as you can. To the extent that you can't, attach it to resources, either on your side or in the PCP office, that have a very clear understanding of how things are going to queue up and how they need to be submitted. With respect to addressing the providers addressing all conditions appropriately, I think there's a couple of different factors there. I think we definitely need to be sensitive to when we ask a PCP to address all of these conditions. Which visit in the year on a patient with a number of highly chronic conditions, which visit are you going to attach this work to? And can you figure out ways to potentially spread it out through the year? So maybe it's not all one visit. Maybe there's multiple visits that you could spread the work out for a given patient, especially if there's a feedback loop to let the provider know what's missing and what remains. I think, though, selecting the right visit, so being engaged enough with a PCP group to understand what visit is appropriate. We see an AWV scheduled. Let's attach our process to that visit, because there should be enough time to do that in the AWV visit is a good example. That's hard to do. It's really hard to do. So if that's not possible on your side or on the vendor side, then making sure that the onboarding is such with the PCP group that they understand this responsibility, that they're taking it throughout the year, that the visits they're attaching the process to are not necessarily all Q4 visits, that they're looking for the optimal visit for a patient as they occur through the year and attach the process there. The number one thing, if the PCP doesn't have time in that visit, then it's impossible to ask them to address all of the conditions. That would be my number one response to that. Anything to add?
I would agree that our main focus has been on annual wellness visit for our Medicare Advantage patients. We were able to get 87% of them done this year. We are very aware of data needs, particularly with HEDIS going all electronic by 2025. We don't get the in-office audits anymore. And we actually now are incentivized to provide monthly supplemental data files to certain payers.
All right, and I've been reminded that the webinar does go to 2:30. So I understand a lot of people are going to jump back into their work days. If you have additional questions, continue to drop them in and we will keep going until we run out of time. Another question that came in, good afternoon. Can you share with us what tool is used for AWV? And I think I have an incredibly biased answer because there's a certain process that we use at Vatica. So to prevent this from becoming a commercial about Vatica, I will not answer the question. I'll let Dr. Porosky take this one. But there are elements to this that I guess the one thing I would put out there is a consistent workflow that can be plugged into each annual wellness visit that ensures that the PCP has the opportunity to go ahead and check all of the boxes efficiently, to get end-to-end on it, understand these are all the elements required for this workflow, and the workflow helps them to understand where they are and when are they finished. I think is one element that I've seen to be helpful in general terms.
And with the annual wellness visit, first, even though we have many practices on different EMRs, we have worked to get a very standardized annual wellness visit for what the content of that visit is going to be, so that we hit all of the preventative care metrics. We are able to close all the gaps in care. But then when we're taking a look at being able to bring together all the conditions, again, we are fortunate that in our area, our major payers all use the same vendor, happens to be Vatica, to pull this together for us, but have adapted to different types of workflow. So some physicians want to get it all done right now, build it in so that they're doing it concurrently while they're seeing the patient. It's nice to have something teed up ahead of time so that they know who's coming in for an annual wellness visit, and stuff is prepared a week in advance so that the physician can go in if they're one of these people who likes to look at their next day's work and see what's coming up to see what they're going to do. There's the option to complete things after you've done the visit. Really, you have to meet the physician where they are, an overused term, but it's the only way that you are going to get the final work product from people who all practice different ways.
And I have one more that I'd like to throw in, actually, after we answer this one. Are there any other important ways to build confidence for a provider who is new to risk adjustment or VBC other than benchmark and pay incentives?
I guess I would stress again that you're not asking them to stress credibility. The more they can see that what you've pulled together is reasonable and it would be easy for them to say, yes, the patient has it, the more you pull in conditions where they realize, oh, I didn't know the patient had COPD. They never mentioned that. And now I've got that information from their doctor in Florida. And that's an important thing for me to be treating, as it becomes an interactive process where they can trust the data that you have sent them and it's actually useful, then I think that you're going to build a partnership.
And I think with this one, knowledge is power, right? If a PCP can request training, if they're leaning in enough that they would like higher confidence in this as a kind of prerequisite for fully engaging, then their ability to come and get training on their terms at their time becomes incredibly important. Once they understand how the math works, once they understand why it's important, I think that's probably number one. Right? Do you understand the blocking and tackling of risk adjustment? High level risk adjustment 101. Don't scare them off. And then the second part of it for VBC, I think there's a natural and understandable hesitance to putting numbers out there for modeling and saying, hey, if we do this, this is what it can look like. Let's bend this number. And if it happens this way, this is what it's going to look like. So creating a pro forma for a PCP organization that wants to lean in on value-based care is, we have seen to be a very valuable tool. It gives them something that they can pivot, turn back, question the assumptions, go more conservative, go more aggressive, but have just the notion of how the prospective nature of Medicare Advantage risk adjustment is going to impact program cost in a given year and program outcomes in the next year with respect to threshold accuracy. See how I just did there? I probably scared half the people off. Sorry. But that's giving them that visual that they can take back. It's a fairly complicated equation. I think that's been incredibly helpful for allowing a PCP group to pivot. It's tough though. There's a balance because you can't make a promise around, if you do this, this is what you'll see. So striking that balance that we understand that we're modeling here. And here's the range we could go in, but this is why it's important. This is what threshold accuracy looks like for you. I think is incredibly important, more at the organization level. That's going to allow PCP leadership to pivot back to PCPs in their organization and figure out how to then, to the previous question, route incentives appropriately to get PCPs to want to lean in that direction and spend some time on this. Let me check to see if we have any more queued up. We do not. We don't have any other questions queued up. I have one though, if we do have time. And this is related to just the idea that change is stress, right? Whether it's good change, bad change, change is stress. And at the top of the call, we talked about the changes in the MA model, the RADV notice, the 2024 final rate notice, these changes, which communicating directly with health plans, I understand the stress on the health plan side. I understand the stresses that this group of changes is triggering on the health plan side and the focus on that side. I guess what would be great to close up with is, how are these changes hitting providers in the market as they grow to understand what the new RADV rule is, what V28 is going to look like? I guess, Dr. Prosky, could you say a little bit about how does that stress manifest itself on the provider side? What are they worried about?
Well, I think providers have two main concerns. One, as CMS is switching from using ICD-9 to ICD-10 codes to crosswalk to the HCC codes, they have made it clear that they are going to eliminate over 2,000 codes that would have crosswalked to HCC scores. And they have expressed that their concern is that they need to curb risk score inflation. Well, I can tell you risk score inflation did not start with the primary care physicians. They didn't know the difference between diabetes and diabetes with complications. But what CMS is now going to do is switch to a methodology that is going to lower risk scores for the same condition. And with those lower risk scores, since many of our primary care docs are capitated, they worry that they're going to be paid less. And honestly, the fact that the risk score changes does not change the patient one iota. They're still going to have the same patients who require the same amount of time and effort to receive care. The PCPs are the last people in the world who can afford to lose ground in terms of what they're paid, but they're worried that the payers are going to say, hey, we're getting less money on this aggregate risk score, so you're getting less money on the aggregate risk score. Do not settle this on the back of the PCPs, or pretty soon you're not going to have any primary care providers. In the last couple of years, we have had 10 primary care practices close. A lot of them were older providers who wanted to hang in there, but it has just become impossible for them between the levels of bureaucracy and the financial constraints that they are facing. So please do not take your already stressed primary care providers. Burnout is north of 60% post-pandemic, and add to that stress level by pulling money back. Find it somewhere else. And then with the RADV audits, which are going to go all the way back to 2011, I would also say do not lay the sins of the past on your primary care providers. Many of them aren't even the same people anymore. And they weren't the people who wanted to code most of these diagnoses in the first place. And so it's going to seem consummately unfair if they are asked to be part of a payback for something that wasn't their idea in the first place, and it might not even have been them. Again, every day you will read, hospital loses $100 million, payer has a, bazillion dollar payback on something. I can tell you with my primary care practices, they can't lose $1 million in a year. They can't lose anything. What they don't earn, they don't take home. And if their expenses outpace what they bring in, they close. They might have a $50,000 line of credit to get them through tough cash flow times, but other than that, there is no backup. And so this is a critical time for the payers to value their primary care physicians and keep them whole.
Great answer. And that's the end of our questions. Thank you, everybody, for submitting questions. It's a pretty good question count. And so I will turn it back over to Rise. I believe you have a survey. Okay, so the survey is up on the screen. We would love to get your feedback on what you thought of this session. And thank you again, and enjoy your afternoons.